Hello, everybody, and you're all very welcome to this evening's session from Croí on living with atrial fibrillation. It's good evening from us here in Galway, and unfortunately, it's a very wet Galway this evening. And it's good morning to some of you, as I know, in different parts of the world. It's fantastic to have such a large interest in this subject. And to reiterate that the session is being recorded. So if for whatever reason you get cut off, you can re-listen to the conversation later on from tomorrow onwards on the Croí website. I'm delighted this evening to be joined by three panelists, and we're going to keep the session relatively informal rather than ask them to make presentations. We're actually going to have more of a conversation. And as we're having that conversation, do please feel free to pose questions on the Q&A as Annie has indicated. We already in the days leading up to this have received literally hundreds of messages, and we're trying to distill them into certain themes, and we'll try and get through as many as we possibly can. Knowing that we're not going to be able to answer all the questions today, I'm delighted to say that in the background, 4 of my colleagues, Aisling, Maeve, Lisa, and Bridget, will be answering questions, as many as they can, live, but on the private section of the Q&A function. And for those questions that are not answered by them this evening, we will endeavour to answer all other remaining questions over the coming days. So this evening I'm joined by Professor Jonathan Lyne, who is a cardiologist and Director of Cardiac Electrophysiology at the Beacon Hospital, an internationally recognized specialist and expert in the assessment, diagnosis and treatment of disorders related to cardiac rhythm. And this includes using the very latest diagnostic techniques and procedures, including cardiac ablation, something I'm sure we'll chat about this evening. He's fully trained in insertion and management of cardiac devices, including physiological pacing, extraction, device optimization, and upgrades. So Professor Lyne, if you turn on your camera there, we can see you. And I'm also joined by somebody who is a very good friend of Croí and supports us in many ways, and that's Paul Nolan, who is the Chief II Cardiac Physiologist at Galway University Hospital, and he's been working in the field of cardiology for over 20 years, fully accredited in the area of electrocardiography rather, pacemakers and ICDs. And our third panelist this evening, again, a good friend of Croí and helps us and has been helping us in many ways in recent years, Eileen Joyce, a psychotherapist, currently working with Quest, specializing in supporting people with acquired brain injury to cope with the emotional and behavioral effects of a health crisis or trauma in their lives. But most importantly this evening, Eileen is here as somebody with lived experience and living with atrial fibrillation. So she'll be able to share her personal experience and also hopefully be able to respond to some of the questions that have already come in with regard to the emotional and psychological dimension of living with atrial fibrillation. So to the panelists, thank you very much. Really appreciate you giving of your time this evening. As I said, we're going to keep it fairly informal and as interactive as possible. So I thought I might start, Professor Lyne, by just asking you the basics of, what is atrial fibrillation? What are its causes? Are there any particular risk factors that predispose it to us? And maybe how is it treated?
Thank you very much, Neil, for the introduction, and thank you for asking me to speak on behalf of Croí this evening. And welcome everyone who's tuned in to the webinar. Atrial fibrillation is the most common heart rhythm disorder there is, and affects many people. It is increasingly common with age, such that at the age of 80, almost 10% of patients will have had AF at some point in their life, and even at the age of 70, up to 5% of patients. So age is one of the most common risk factors, but can occur really at any age at all. It's associated as being of increased risk in patients that have other cardiac disease, such as artery disease, high blood pressure or hypertension, valve disease, particularly one of the valves called the mitral valve, and heart failure. There's a lot of other potential related medical conditions that may increase the risk, but we won't go through all of those. Really, what atrial fibrillation is that in the top chambers of the heart, or the atria, there are specialized cells there that set the rhythm of the heart. They're the pacemaker cells of all our hearts. And that in some patients, extra beats can occur in those top chambers, and sometimes they're very fast. And if you like, they can disorganize the rhythm of the heart and override that pacemaker group of cells, and result, instead of a single organized electrical activity of the heart, it can actually result in it being chaotic and sending an irregular signal down to the bottom chamber of the heart, and end up with an irregular pulse that can be fast, and something that people could be aware of in terms of symptoms.
Okay, so just following through on that for a second, you made reference there to the pulse, and in fact, one of the questions was, what is the significance of pulse and atrial fibrillation, or what's the link?
So in patients with atrial fibrillation, almost always the pulse is irregular, because instead of having the regular activity of the heart set by the pacemaker cells, it's become disorganized in those top chambers, and hence the signal that's sent through to the bottom chamber, which are the ventricles that cause, if you like, the blood to be pumped around the body, and we feel that as a pulse in the wrist or the neck, that pulse has become irregular, and it is no longer regular in almost all patients. And hence the pulse can be felt to be irregular in most of those patients.
So actually checking a pulse is one of the first indicators, would that be correct?
Exactly, yeah. And I think there have been campaigns of called Know Your Pulse, and checking that on a couple of times a week to be sure that, you know, it is regular, and is a very easy screening tool that a lot of people can do.
Okay, and if I can just continue with you just for a few more seconds, and you've outlined there many conditions that run in parallel or are comorbid. Which comes first, or it's not as simple as that? Is AFib a side effect of other conditions, or does it cause other conditions?
Yeah, it can be either way around. So I think conditions that we mentioned, artery disease, blood pressure, heart failure, can certainly be related in how atrial fibrillation can develop. So if those top chambers that we talked about that become irregular in their activity, if they're under stretch from that valve disease, leaking blood back into those chambers, if there's high blood pressure and they're stretched and under pressure, atrial fibrillation is more likely to happen, I suppose, as a secondary effect to that. But equally, as a primary effect, if the blood pressure, the AF might be quite fast in the rate of the heart, then that can result in the heart not being as effective, and potentially causing heart failure over time as well, if you like, as a secondary effect to the fibrillation alone.
Okay. I know that from a Croí point of view, when we're and when our health team are, you know, speaking to the public in various scenarios, we try and make the distinction, which is often perhaps confused in the public mind, between, say, cardiac arrest and heart disease and heart failure and so forth. And we talk about atrial fibrillation as an electrical problem. Is that fair to say? And generally speaking, when we talk about heart disease, or ischemic heart disease, you're talking about a plumbing problem. I think it's a reasonably good analogy. But can I ask you, what is the impact of it, though? Not from the Eileen will tell us what the impact is from the point of view of living with it, but is it dangerous? What can it lead to?
Sure. I think I describe this to patients really as being two main silos, if you like, that I talk about when I talk to patients about atrial fibrillation, about how it may affect them over time. Firstly, we talk about the symptoms that AF can cause. And by that, I mean, if the heart is irregular and potentially fast, they may be aware of palpitations. They may be aware of the heart being fast. They may get breathless from that. And we talk about how that may affect them or may not affect them, because some patients can be asymptomatic and not know at all. But really, we're talking about symptoms in particular. Secondary to that, I talk about the stroke risk. And these things are, to a large degree, completely independent. By that, I mean, you may not have symptoms, but still have a stroke risk that may be quite high, and vice versa. So there is a link to a degree, but I would really treat them as being quite independent things. So the second thing is the stroke risk and assessing what is the likely or possible level of stroke, and how should we manage that? Is there somebody that needs to have a blood thinning type of medication, a warfarin type medication to thin the blood and reduce the risk? And there's several other procedures that can be done to help with that as well. And really to reduce the risk of stroke as being, if you like, the second silo of AF management. Symptoms and AF are really the two main things we talk about.
Okay, and finally, for now, just that point about the stroke risk. How well linked is atrial fibrillation to stroke? Is it like is it one of the major causes of stroke, or could you comment on that?
Yeah, definitely. So atrial fibrillation is probably the major cause of stroke in the Western world. The valve disease and rheumatic fever in Asia probably ranks very highly as well, but in the Western world, atrial fibrillation, one of the most common. The risk of atrial fibrillation causing stroke is probably 5 times higher. So a patient with AF 5 times higher stroke risk on average than a patient without atrial fibrillation. Now, we can be more specific and help to categorize that in individual patients, but I'm talking about as a group of patients 5 times higher. And with atrial fibrillation as a diagnosis, strokes tend to be denser and if you like, a larger symptom burden or larger deficit for a patient afterwards than it would be from some other conditions. So stroke risk is a significant issue, and an atrial fibrillation is certainly one of the biggest risk factors.
Okay, I had asked you about treatment, but I'll hold that for the moment, and maybe we might, because what you've just described there is the perfect lead into you, Eileen, if that's okay. Just before we came on here, we were chatting about your story. Can you sort of give a brief synopsis with particular reference to when you first realized you had AFib and that experience?
Well, I suppose going back there to the link maybe with stroke and AFib and stuff. About 3 years ago, I had a very slight TIA, which I felt very lucky to have been caught very early. And at the time, they did do a heart check and found no reason or no issue arising from that. Nothing showed up. And then during lockdown last year, when we first started after the first lockdown, I started to get a lot of breathlessness coming up the stairs, and I wouldn't have any other, significant kind of causes. Like I had no high blood pressure, no cholesterol, or no high cholesterol, or not diabetic or any of those things. But for me, actually, it was just the breathlessness. And for quite a while, I was pushing it because I thought, oh, I've just totally unfit after lockdown and I just need to get out there and push it a little bit more. And luckily, I got it checked out before I went too far, and I was diagnosed with AFib back in probably September, October. And put on medication to kind of regulate it, and waited to have a cardioversion done. And I ended up in the hospital twice to have cardioversion done. Very frustrating, I have to admit, because both times I was in perfect sinus rhythm. So I couldn't get it done. So that in itself can be frustrating, because you wait a long time for your appointment, and then you go in and it doesn't happen. But then I had an angiogram done, and they discovered that I had some blockages in quite a number of blockages. So I ended up with 5 stents, and thought, well, that might take care of the AFib, but it did for the first few weeks. But I've discovered that I'm kind of back in and out of AFib again. And I suppose just to say there, the last thing that you said there about, you know, the high likelihood of stroke with AFib, I feel very blessed and lucky to be diagnosed and to have, you know, be on the medication and have the care taken, because I feel less likely to have a stroke now than if I was walking around like I was before, unaware that, you know, that I could have been just a walking time bomb, really. So I think, you know, my message to people there would be, rather than fear, oh my goodness, if I've got AFib, I'm going to get a stroke, would be, you know, if at least if you are diagnosed and you know it, and you can get support and help with medication, there is at least, you know, okay, you're in the higher risk category, but you're in a very high risk category if you don't know. You know, so it's better to have the information and to be able to do something with it.
Yeah, that's obviously a word of encouragement there in terms of. Can I jump back to you, Professor Lyne, before I go to you, Paul, because to just pick up on two things there from Eileen. First of all, as I said, we were chatting before we came on live here, and Eileen has clearly indicated it's almost like two things happening. There's underlying cardiovascular disease. She's had stents, and she's had atrial fibrillation. And so she was describing the symptoms there. Would it be right to say that the symptoms she was describing of breathlessness are not the typical symptoms of atrial fibrillation? Is that the case, or are there typical symptoms that would suggest atrial fibrillation?
I think the issue is that atrial fibrillation can pretty much present, firstly, with no symptoms, and secondly, with virtually any cardiac or cardiorespiratory symptom. By that I mean it can be breathlessness, it can be palpitation. The Americans say a fish flopping in the heart, or the heart turning over, a washing machine in the chest, all sorts of different descriptions. But it can be a very mild symptom to a very specific symptom like breathlessness, or an awareness of the heart pumping in the chest, or palpitation. But it can be very minor, or can be something. I'd say breathlessness is a relatively common symptom for presentation of AF. I'd say probably 20 to 30% of patients both present with a degree of breathlessness.
Okay, and then to the point of TIA, which people would loosely describe as a mini stroke. Can you tell us a little bit about, maybe even tell us, what is a TIA? What is the significance of it? What is its linkage to AFib?
Sure. So I suppose a TIA, like you say, a mini stroke, it is by definition a neurological deficit. So an alteration maybe in speech or motor function, doing something, sensory function or vision, lasting less than 24 hours. So a non-permanent neurological symptom. In relation to AF, then look, there can be small clumps of blood clots that may go up to the brain or to the back of the eye. They may result in a symptom like this that resolves, and the body breaks it down, and blood flow is restored by itself without permanent loss of function. But I suppose it is a warning sign with respect to the risk of stroke. And in patients that have had TIA, the risk of them suffering a further event or stroke is higher than patients with AF that have not had that event before, and managing them appropriately in terms of blood thinners and other options are important, as well as, I suppose, keeping them in normal rhythm as much as possible, be that by drug medications or procedures such as ablation. So it's really important to manage patients with AF in general, but specifically if they have had, I suppose, a warning event like this.
And if somebody presents with a TIA, is it automatic that you search to rule out, from a clinician's point of view, that there is underlying AFib? Is that
Yes.
Is that a normal part of the care pathway? Yeah.
Yeah, exactly. Yeah. So I think searching for causes for AF, particularly, or for TIA or stroke in young patients, is extremely important. It is definitely something that should be done to quite a high degree, I suppose, of investigation. By that I mean heart rhythm monitoring, structure and function of the heart by ultrasound or other tests. Artery disease, as Eileen talked about in terms of arteries, can be part of it. but particularly the rhythm of the heart, sometimes with quite long-term monitors, even including implantable monitors, because we know from a number of studies that patients that can present with a stroke but have had AF and not be in AF at the time of that event, and equally patients may develop AF after the stroke or TIA, but not have had any rhythm issue before. So it doesn't have to be that you're out of rhythm to develop the event at that time. It can happen both before the AF or after or at the time.
And actually, talking about investigations and monitoring and so forth is the perfect lead in to Paul Nolan. Paul, sorry for keeping you so long before getting to you. I know you, I know what you do, but I introduced you as a cardiac physiologist. So for people who don't know what is a cardiac physiologist, can you tell us a little bit about the work of a cardiac physiologist, just briefly, and then how it relates to AFib?
Yeah, it's a good question. It's something I have to remind my wife sometimes what I do, because she's not quite sure either.
But she knows you don't do the washing or the cooking. But what do you do?
So we perform and report most of the cardiac investigations, particularly like all the non-invasive ones. So everything from your heart tracing, your ECG, up to the echo, the ultrasound of the heart that looks at the structure and function, exercise testing. We look after patients' implantable devices such as pacemakers and defibrillators and loop recorders, which we'll probably talk about later on. And then the heart rhythm monitoring that Professor Lyne talked about, like Holter monitoring and some longer term monitoring. And then we also work in the cath lab where Eileen would have had her angiogram and had her stents put in, monitoring the heart rhythm and pressures. Obviously, then we play a role in education sessions like this, both at a local level.
Okay, and then specifically with AFib in your day-to-day job, what is your interface with people living with AFib?
Well, obviously, there's a significant number of patients who come to us who either are potentially they're looking for a diagnosis of atrial fibrillation, or their clinicians are, or they already have atrial fibrillation and they're being managed. And some of the ways that they might be managed, as Professor Lyne said, one of the ways is trying to control people who are in AFib all the time. Is trying to control how fast the heart goes to control their symptoms. So some of our tests, such as Holter monitoring, where we record for 24 hours or 48 hours, might be looking at how well the rate is controlled over a certain period of time. Other monitoring, we might be looking at seeing if somebody develops episodes of atrial fibrillation like Eileen. So some patients have it all the time, and we call it permanent atrial fibrillation. And other patients go in and out of episodes of atrial fibrillation, and we refer to that as paroxysmal. So monitoring sometimes picks up those events, particularly if patients are asymptomatic. And then with the echo, patients who develop new atrial fibrillation, we want to find out, is it because there's a structural problem in the heart? Is it because a valve is leaky or a valve is narrowed, and that's putting pressure on those top chambers and causing them to go into that atrial fibrillation state, or that sort of slightly chaotic state? So that's a significant part and chunk of what we do.
You mentioned diagnosing AFib. How do you diagnose? How is AFib diagnosed? And maybe more specifically, if my doctor refers me to you, for example, what can I expect you're going to do in terms of the diagnosis piece? And is it invasive, or what's involved?
Yeah, so I'd say most GPs will have the ability to perform the 12-lead ECG, so where they put the stickers on the chest and the wrists and the ankles, and that gives about a 10-second snapshot. So if you happen to be an AFib at that time, it'll pick it up. But most of the time, that's not the case, and there's a suspicion. And in general, the most likely test somebody will have done will be a Holter monitor, which is a small monitor that you'll wear for anything from 24 to hours to maybe up to a week, depending on the suspicion or depending on the history. So, for example, in Eileen's case, somebody that would have had a TIA, typically the best scenario is to monitor them for 72 hours. So typically a Holter monitor, even sometimes a smaller type of monitor we use in Galway, is an R-test monitor, which and those monitors have 3 stickers on the chest. It's smaller than a mobile phone, clipped to your belt or somewhere discreet. and you go about your day as normal. So you come in, get it fitted, and go home, and then return it, you know, at the end of the monitoring period, and we analyze it and give a report to your clinician.
Okay. We'll be talking about some of the devices in a few minutes, and we'll come back to that. So talking about leading on from, I've now gone to see you and you've done some tests, and I end up with Professor Lyne. Once you have a patient sitting in front of you that has diagnosed AFib, broadly speaking, what are the treatment options? Are they invasive, less invasive? Is it medication? Again, just from the point of view of somebody who's just been told they have AFib, what can they expect in terms of the treatment pathway?
Is that for me?
Sorry, for Professor Lyne, sorry.
Okay.
Yeah.
So I suppose in treat, I think once, you know, Paul has completed investigation, so commonly patients, like you say, will have been diagnosed either by ECG or on the monitor. Often they would have had tests like the ultrasound or echocardiogram of the heart, like he said, to confirm that the heart is structurally normal. There isn't a valve narrowing, leakage to fix. And many patients may have had an exercise test or some assessment of artery function, maybe a CT or MRI scan of the heart. After that, when it comes down to treatment, we really look at those two silos, symptom control and stroke risk. So in terms of symptom control, we're really looking to give them best quality of life possible and freedom of symptoms. So we would normally start with, if they're in AF all the time, as Paul said, so a persistent fibrillation or a permanent fibrillation, controlling the speed of that heart, maybe with medications like beta blockers, used in many heart conditions, blood pressure and artery disease as well, but specifically to slow down the heart, the pulse, if you like, not necessarily to regularize it, but to give them a better quality of life. And secondly, for some patients who go in and out of rhythm, specific rhythm drugs. Now, beta blockers are part of those group as well, but there's other more specific drugs we can use of various, if you like, strengths and have specific side effects and issues you have to consider, but really to try and keep them in rhythm as much as possible. Secondly, we'd be discussing whether this is somebody who maybe is going to be in what we would call rate controlled fibrillation going forward. So whether the aim would be just to control the heart rate, but not aim to get back to normal rhythm, or whether this is going to be somebody where we're really looking to get back and keep normal rhythm in the long term, you know. And so that would be talking about medication initially. And then if we're looking at other options, we would look at procedures such as either a cardioversion, as Eileen mentioned earlier. That's a reset back to normal rhythm by a shock externally under sedation or anesthetic. If you like, that's a reset, the same as rebooting your computer or you're starting your car. And secondly, procedures such as an ablation. An ablation is really identifying and burning or freezing away specific pathways in the heart that are responsible for both initiating AF and also maintaining AF. And we do different procedures in different patients. But largely speaking, that first discussion is this AF somebody we're going to manage just in the rate, but allow this person to be in AF, but give them the best quality of life possible? Or is this about getting back to normal rhythm and keeping normal rhythm going forward? And is that going to be medication or procedure? The second issue is stroke risk, and that's about blood thinners. Okay,
so just on the point, do I infer from when you start with the symptom control, do I infer from that to that in lay terms you can't cure it, you can't stop it? Is that the?
I think for many patients you probably can. Now, I'd say that with a slight hesitation that unfortunately for many of these treatments, the risk of recurrence of AF still remains not insignificant. Now, the risk of recurrence from medication, from cardioversion, or from ablation, from that procedure is different in different individual patients. So in patients who have atrial fibrillation that comes and goes, as Paul mentioned, paroxysmal, who are younger group, who don't have artery disease or thyroid or liver, or other heart problems, blood pressure, the results of ablation in them is very, very, very good. You'd be looking at sort of a cure rate, if you like, of at least 95% from a single procedure. But in patients who have underlying heart disease in an older age group, you might be looking at a recurrence of 40%, you know, and I'm talking about a recurrence risk maybe per year, so not insignificant. So I'd say, to say it's not curable, probably not true, but to say that we can cure all patients with AF, then no. I think really the primary thing is quality of life and the reduction of stroke risk to the minimum we can make it, and with the safest method of getting to that point.
Okay, so for a lot of people, it's about living with it in as controlled a manner as possible. Okay.
Yeah, exactly. Controlling symptoms, managing stroke risk. Now, but for many patients, that does mean aiming for normal rhythm going forward, by either medication and or procedure if needed. Okay.
Eileen, this is a good lead into you, because you've been there, and as I understand it, you are there, as in you have untreated as such AFib. Well, untreated is probably the wrong way to put it, but you're living with AFib at the moment. Just for somebody maybe who's listening and wants to know, well, what's it like? What what's the physical experience like, first of all?
Well, my life is quite normal. My life has gone back to being quite normal. I'm back full-time at work. The only thing it can be very frustrating and quite can be stressful at times to maybe plan things ahead of time, because you just need to be mindful that there is a difference to the days that you kind of are in AFib, or the times you're in AFib to the times you're not. And because you're constantly having to take the medication and that you are possibly more fatigued and stuff, it certainly changes your life in a way. You're going to have to look at making major changes in your life. But I suppose it's to take the fear out of it, and it doesn't limit you completely. It's you can still have a very good quality of life. I think what takes away from the quality of the life you are is if you, which I did, I think for the first few months, I just used to get very frustrated. I'd get frustrated at the things I couldn't do. I'd get annoyed with everybody around me when I couldn't do things. I was in the middle of moving house. I was in the middle of doing all kinds of stuff. And I would normally be a very physical person as well, working physically. So that can be very frustrating, and you just need to, take a step back and be a little bit kinder and gentler to yourself. And when I say learn when to stop, I'm still learning when to stop, and I haven't gotten there. I may be preaching it and maybe not practicing it as well as I should. But I suppose you do know sometimes what triggers it. I know certain events or certain things I will do will trigger it. So it is about, getting to know yourself a little bit better, getting to know your own patterns, getting to know your own, what stresses you, what are the things that might push you or make it more dangerous for you. So it's about taking time out and be willing to look at that.
If we can just go a little deeper there, when you say things you can't do because of it or what triggers it, the it piece, is this the symptoms you're experiencing, and what are they? Is it just exhaustion, or is it the physical pumping in your chest, or what, pounding in your chest, or what?
It can be anything from pains in your chest to, for me, it's mostly the breathlessness. Upstairs, if I walk upstairs, I'll have to sit down when I get to the top of the stairs. Heaven forbid I should have to run away from somebody or something. It's, I wouldn't get very far. So most certainly, there are limitations to it. But I noticed that, there is also, I suppose, side effects sometimes with the medication. They can be sleeplessness, there can be, hot flushes, there can be all kinds of stuff that you can go through hormonally that can happen with it. But again, it's what I found to be really, really fantastic, I have to admit, was I'm somebody who likes to have a bit of knowledge or to know what's happening or to find out something about it. And I have to admit that, you know, the HeartLink team and HeartLink West, you know, all I had to do was ring somebody there, and anytime I was kind of concerned or unsure, you know, they were very reassuring, and it was great to have that support, because I think the biggest and also the biggest thing I think that happens is you're not sure how far you should be pushing yourself or not, because you're supposed to get fit, you're supposed to, you know, watch your diet and get exercise in and get as fit as you can, you know, within it. But there's always that concern, am I pushing it past the limit? You know, am I pushing myself too much here? And it's great to have exercise programs. It's great to talk to other people. It's great to have that support, because it's a learning process, you know, for you to find out what your heart can do again, because, you know, how do I trust it again?
Yeah,
you know?
we might come back to the psychological piece of it again later on. Paul, Professor Lyne mentioned there about the treatments, cardioversion, ablation, but obviously there are also device treatments. Can you talk to us a little bit about what are the devices that are used to treat AFib, and what's the reality of I suppose living with a device and having a device implanted?
Yeah, I suppose in the area of atrial fibrillation, one of the most quite a common device is an implantable loop recorder, and they're quite often used in patients who've maybe had a stroke or TIA, and we're looking aggressively for atrial fibrillation. And those devices are small. They're you know, the best comparison I think is about the size of a small pen top, and they can be, you know, a Bic Biro lid, and they can be implanted just under the skin in a very simple procedure. They're expensive, but the battery in those lasts up to 3 years, and they are monitored remotely. So the patient has a little unit at home, and it communicates via mobile phone technology and the internet. And they really are excellent at picking up atrial fibrillation, because they're analyzing the heart rhythm all the time. Devices that actually treat atrial fibrillation. So yes, you can have special types of pacemakers that will recognize atrial fibrillation and try and convert the rhythm by either pacing the atria very quickly, which a patient mightn't feel, or delivering a small shock to the atria. And typically that, because it's not an emergency situation, typically that shock would be delivered maybe in the middle of the night when a patient would be asleep. But certainly in my practice, in my experience is we don't see a lot of those devices implanted in Ireland. Maybe Professor Lyne sees more of them, but certainly we don't. The other type of device that very often people end up are patients with atrial fibrillation that might end up with, particularly patients with permanent atrial fibrillation, is a pacemaker. And it's not there to control the atrial fibrillation or stop the atrial fibrillation. What can happen with patients with atrial fibrillation over time is that either we have to increase their rate controlling medication to keep them free of symptoms, but that makes their heart rate go too slow. And then if you try and ease back the medication, then their heart rate goes too fast and they get symptomatic again. And in those patients, we put in a pacemaker to stop their heart rate going too slow, so that we can give them enough rate controlling medication. And then sometimes patients just over time become slow over time without any changes to medications, and they get pauses or slower heart rhythms that cause them to become lightheaded or dizzy, or even potentially blackout. And in those patients, once we have identified those slow heart rhythms, the pacemaker is put in to make sure the heart rate doesn't drop below, say, 50 or 60 beats a minute.
Okay, and just to recap there on the loop recorder, its purpose is purely diagnostic. It's just this is for somebody like where it's difficult to confirm that they are having AFib. Is that it?
Typically they go in for two main indications in our practice. One is blackouts, where we can't identify the cause, and particularly if those blackouts are quite sporadic. So if someone has a blackout and they had one 2 months ago or 2 years ago, then trying to capture that on a short-term monitor can be difficult. Or in patients who've had a TIA or stroke, where we're aggressively looking for atrial fibrillation.
Okay. So that's very helpful. Looking and keeping an eye on time, I think we've got a good overview of what it is, some of the causes, how it's treated, what it's like living with it. If you're okay, I'll now move to questions, and these are not necessarily going to follow any particular sequence. So if you're happy, I'll just fire them at you and see how you feel about them. So let me see. Okay, here's one. If I have, maybe I'll give this to you, Professor Lyne. If I have AFib and I'm taking AFib medications, which you've made reference to before, any implications for somebody who's also on medication for erectile dysfunction?
I suppose that the issue there is that a number of medications used to manage AFib, such as beta blockers and some of the other rhythm drugs, can make erectile function worse or increase dysfunction. And so I suppose some of the medication may make that symptom worse. There's not necessarily a conflict in the two medication groups, largely speaking, but of course, if AF is part of a wider vascular disease, high blood pressure or artery disease, a lot of those anti-anginal medications equally can cause erectile dysfunction. So it may be coexisting conditions rather than drugs specifically or only.
Okay, thank you for that. Let me see. What do we got here? Maybe Paul, I'll give you this one. I have high blood pressure, high cholesterol. How do I know if I have atrial fibrillation? What kinds of tests should I get done, or can I get done, or do I need to get done? So somebody with high blood pressure, high cholesterol, and now they're listening to this conversation about atrial fibrillation, and they're thinking, is there a link between them?
So I think, and maybe Professor Lyne wants to come in, but I think if you have cardiovascular risk factors, particularly high blood pressure, it does put you at increased risk of rhythm disturbances. So if someone's got high cholesterol, there's a chance they maybe have high blood pressure but don't realize it. So I think as a general sort of comment, I think if people are worried about atrial fibrillation, or if they're patients who have episodes of atrial fibrillation, I think learning about how to take your pulse. Also, I think there's an increasing market for patient-owned devices. So before you even get to a physician, and I think the last look, there was something like 60 potential heart monitor type devices that patients can buy for themselves. And I think anything that gives an actual heart tracing that you can bring to a physician like Professor Lyne and say, look, I had my palpitations, this is what I had. And my personal feeling is the Apple Watch is reasonable, but a very reasonable type of device, and one that's very good, I think, it's the Cardia device. It's literally two metal strips on a black bit of plastic. You can stick it to the back of your phone. It links by Bluetooth to your phone, and you put your two thumbs on the phone on the metal strips, and it records a 30-second heart tracing. And you can make multiple recordings, so you can have a couple of examples to bring to a clinician. And I think that type of thing can be very, very useful. If you don't have it's 100 to 130 euro to buy that, so it's a very reasonable once-off cost for a device that you're going to own. And I can't remember the last person I met who forgot their phone. People always bring their phone with them. So yeah, I think that bit of technology is a little bit of a game changer, I think.
So you've raised a couple of things there that I might just refer to you, Professor Lyne, on. So firstly, the question, I have high blood pressure, I have cholesterol, should I go and get checked for atrial fibrillation? It's obviously an obvious question if you're sitting and listening to this conversation. But what would be the general thing about actually looking for atrial fibrillation? I mean, is it something you mentioned it's age related, for example. Should we be checking for it? And if so, how do we check? And who should be the group that's checked most, if you will?
Sure. I think certainly there are screening screening events or screening opportunities, I suppose, for AF. Like many patients are having, if you like, a COVID vaccine at the moment, or will be having a flu vaccine at some point, I suspect, in the next 12 to 18 months. So opportunities where they are having other healthcare things managed, maybe diabetes, maybe blood pressure, maybe they're having a blood pressure monitor in the clinic with somebody like a Paul or a physiologist. There are opportunities where people are with healthcare individuals that will either get an ECG done or could do a pulse check at the same time. And that is certainly something that has been promoted elsewhere in the world, that you use these opportunities where you're seeing maybe a practice nurse, maybe a GP, pharmacies, some places, as Paul said, the Cardiac Monitor. I certainly have many patients who have shared, if that's the right, and other friends or family members have used their monitor and picked up AF. And I think in individuals at risk, like you say, high blood pressure, other artery disease or other heart failure type diagnoses, then look, screening for these things can be very useful. And it can just be a pulse check and to feel the pulse in the wrist, like we've discussed, or something like a watch or a smart monitor.
Yeah, it's one of the projects, actually. Croí as an organisation, we're actually piloting right now in County Mayo, where Eileen is from, and we call it our Third Age project. And the idea here is that, as you mentioned, atrial fibrillation is largely age-related, and there are a number of other age-related conditions. So, an annual pulse check, we're advocating that for people as they sort of hit the third age, 60 plus. So that seems to be consistent with your message. Paul mentioned the new devices, the Apple Watch and so forth. I imagine clinicians will vary in this, but digital technologies are here to stay, and patients are, not patients, the public are more inclined to be using these. What's your general view on how receptive or otherwise clinicians are to this idea? So Paul was saying, anybody can buy these devices. Is that good or bad from your point of view? Do you respect the fact that a patient of yours might be monitoring regularly? Is it helpful or otherwise? Just your thoughts on that.
Oh, sure. No, I think you're right. I think they're here to stay. I think they're very useful. I think they're extremely cost effective for patients. I think they're very reliable. I think their accuracy is very good. Paul mentioned the Cardiac Monitor. I think it's an excellent monitor. It actually has an FDA medical device approval. I think they're very good monitors. They're accessible, as Paul mentioned about people, they've always got their phone on them. The chance to get that recording of what might otherwise be a very infrequent symptom, they're very good monitors. A lot of my patients have them and bring recordings with them. They may have printouts, they email us, myself or my nurse. And again, for follow-up, they're very useful because patients may have these procedures that we do for them. They may go away and often we might, if you like, cure or treat their AF, but they may get extra beats. It can be very concerning for them. And they want to send us that symptom and say, look, is this the AF back or not? And you can say, look, no, it's extra beats. You're aware of it, but you've proven to me by using that monitor that it isn't AF. And we use that for a lot of different heart rhythm issues, not just atrial fibrillation.
Okay. Eileen, if I can jump to you, quite a lot of questions coming in, I guess, relating back to the way you described, the sort of the frustration and the uncertainty and so forth. And you can answer this as a psychotherapist or as somebody with the lived experience, but a number of questions about people saying, feeling very anxious, even to the point of, panic attacks when the physical symptoms become obvious. People saying my quality of life just deteriorated. I feel badly. I feel older than I feel like an older person. There's a whole lot of them here. The unpredictability. I'm on edge. Any words of comfort to these people, or what would you be saying?
Well, first and foremost, all of the symptoms you described are very, very normal to go through. because it is very traumatic. And I suppose it's also the uncertainty and the not knowing, and sometimes and particularly now in COVID times, sometimes even the having to wait for, an appointment, or not knowing when you're going to get one, or that whole path, particularly in the last year, has been very, very difficult for people to do. But I suppose what I would say to people, very, very much in that sense, is you have to think of, in a way, what parts of it can you control? There is so many uncontrollables in it that you're not going to be able to, handle. So what are the areas, what are the aspects of it that you can take charge of, that you can work with, and a little bit like, I think the more anxious we get, and we can get ourselves into huge panics around, be it going in for an angiogram or going in for a test or going in and getting results. And a lot of people now have had to go in on their own and not have support in there because of COVID and all of that. But it's a little bit around thinking that, the more you focus on how dangerous this is, will I get a stroke, and because it does have a risk factor. But it's a little bit like, looking at your own resilience, looking at the type of person you are, how have you dealt with things before, how do you deal with any crisis? And it's a little bit like, can I put a plan in place for my heart? Can I put a plan in place? What are the parts and the aspects of it that I can take charge of? There might be very little, but it might only be how you respond or how you react to something. And if okay, I need to have somebody with me, or I need to share it with somebody, I can't handle this on my own. Anxiety can be huge and panic can be huge, but you have to remember that's only going to stress you out more. And the more stressed you are, the worse effect it's going to have on your AFib. So it's a little bit like blood pressure. You have to remember, stress is like blood pressure. You need to have it, but if it goes up too high, you're going to have to find a way of de-stressing. So it's very important that you find ways of lessening the anxiety and working with anxiety. There are certain techniques and different ways that you can work with anxiety, so lower it, and it can be quite different for each and every one. But to know it's normal, and you might have to reach out there and get support and help, be it from wherever you can get it. But I think informing yourself, knowing how much you can do for yourself, can really help.
Okay. Paul, there's a bundle of questions here I think are sort of in your domain. I might start by asking this one, because you're obviously doing tests, you're seeing people presenting with query AFib. Is it more a male or female thing, or would you, from your experience, or what is is this a male or female condition, or is it equally distributed?
I think it's equally distributed in terms of the patients who are coming to us, but maybe Professor Lyne can comment. But certainly it's something of concern with older age, certainly. So the older you are, the more likely you are to develop atrial fibrillation, and the side effects of it. But we do still see young people present with atrial fibrillation, and sometimes binge alcohol can be a trigger in some patients. So the causes can be varied across the age groups, but I don't see a gender difference myself, but maybe Professor Lyne does in his practice.
Okay, Professor Lyne, just a quick question, quick response to that.
I think the true prevalence is probably very similar between men and women, but women are underrepresented in many cardiovascular diseases and trials due to probably under investigation and not presenting early enough, or not presenting to have the test done when symptoms occur. So I'd encourage everyone to get screened or checked. I'd encourage women particularly to come forward if they feel they may have symptoms of concern at all.
Okay, Paul, this is a local question, and you might be able to answer this. So somebody has had a cardioversion which we've learned already, is this procedure where, am I right to describe the cardioversion as the heart is shocked and restarted? Is that the simplest way of describing it? And they want to know, and I said, I'm told I need an ablation, but this cannot be done in GUH. I don't have private health insurance. Will this ever be available in Galway?
So I think it's the one thing that's missing from our service currently. So for years we campaigned to get cardiac surgery in the west of Ireland, and you know, there's a huge appetite to get a full electrophysiology service because you know, having that ability to deliver the newer techniques and develop that service. So it's a challenge of trying to attract a new qualified consultant back to start a new service. That is a challenge, and even just attracting consultants back to Ireland currently is a challenge, as people will have known from the media. Like, there's over 500 vacant consultant posts, so there's a real desire to get it in GUH. And we've advertised a number of electrophysiology positions that unfortunately haven't been filled over the last couple of years. And we do have close relations with the hospitals in Dublin in terms of referring people onwards, but obviously there's a real need to have that service in the west of Ireland.
So related, and it's a political question, in the Celta region, as a public patient, how do I have an ablation?
So by seeing one of the cardiologists in the west, trying to have your diagnosis made, and then asking for the potential for that treatment to be investigated in one of the Dublin hospitals, and getting an onward referral.
Okay, so that's interesting. It's something that maybe Croí needs to look at in the context of, you know, a service. There's another question here, and I'll give it to you, Paul, and they're flagging me here on time, and it's probably related to this. Well, there's two. One is that I've had 4 cardioversions and I was never offered or mentioned an ablation. And the other question about cardioversions is how many times can you have a cardioversion? So I don't know whether yourself or Professor Lyne would like to.
Yeah, so I think briefly about the offering of the ablation, and Professor Lyne can comment on this, but the ablation is best suited to certain types of individuals, maybe people who are a little bit younger, symptomatic, and whose hearts are, there's better outcomes for people whose hearts are structurally normal. So that's potentially maybe why it wasn't offered, but also because we don't have somebody on site doing it, it's maybe not to the forefront of our mind as much as it should be, and that's one of the disadvantages of not having service in the West. I don't know if Professor Lyne wants to comment further.
Yeah, sure. I think that ablation is there as a treatment for symptoms of atrial fibrillation or preventing recurrence, either in patients that don't want medication or patients who have failed or had side effects of medication. As Paul said, the outcomes or the recurrence is higher in patients who have structural heart disease, but still they can be the patients who have most to gain in terms of symptoms, and that's true of many cardiology diagnoses. But it is certainly younger patients who have episodes that come and go, paroxysmal AF, and those with structurally normal hearts that do better. And it is certainly something where we need to increase provision of electrophysiology services across the country, as Paul mentioned, and particularly to access ablation, which currently is through the Dublin hospitals, and certainly something that we do a lot of through the current, if you like, surge agreement at the moment for public patients from Galway and from some of the other public hospitals at the moment in large numbers.
Okay, I'm going to be beaten off the stage if I don't control the time situation here. We're right up on the hour. Can I ask, because we've got some very good perspectives, obviously, this evening from the point of view of living with the condition, Paul, from the diagnosis, the detection and diagnosis and treatment, and likewise from you, Professor Lyne. If I was to ask each of you to leave us with what you would see as the most important message you feel the general public should know about atrial fibrillation, what would that be? If you were to sort of, if everyone was to go away from today this evening after listening to this conversation, what's the one thing you'd like them to either know or do about atrial fibrillation. Professor Lyne, can I start with you?
Oh God, there's a lot of things I could potentially do. I think number one, get diagnosed. Number two, know your stroke risk and be appropriately managed to, decrease the risk of stroke and the downstream events. Number three, improve quality of life, be it drugs, be it ablation, be it a pacemaker, as Paul said. But those are I suppose I've chosen three there. But
yeah, no, that's fine. That's fine.
That's it.
Yeah, but on the positive note, if I'm hearing you correctly, it seems there are, while it's a very debilitating condition and has risks, it seems that largely speaking, there are ways of either managing the condition and reducing the risk. That we're in would you say in a reasonably good place in terms of?
Yeah, there are options. There are options to significantly reduce stroke risk, symptom burden, and reduce medications and make some patients medication-free and symptom-free.
Okay, Paul, if I can go to you next, from your experience, you're seeing people every day. Well, maybe not every day, but you're seeing a lot of people with atrial fibrillation. What sort of, if you were to give some key messages about AFib, take-home messages, what would they be?
Yeah, I think it reflects what Eileen said yesterday. I think learn about AF. So if you're diagnosed with it, learn about it. Learn how to check your pulse. And I think one of the things that we didn't touch on is one of the other pillars in terms of AFib treatment is risk factor management and lifestyle management. And it hadn't struck me until I sort of read up on this recently. By losing 10% of your body weight, it reduces your risk of AF sixfold. Exercising 150 minutes a week, which sounds like a lot, but you can build up to it, and any movement is good movement. We know that from studies that can reduce AF symptoms and also reduce the amount of AF. And I think, there's still a lot that, the medications are great, the treatments are great, but there's still a bit that patients can do for themselves to both prevent their risk of developing AF in the future, and but patients who have AF, reducing the amount of symptoms and the amount of it that they have. So I think learn about it and try and modify your risk factors as much as possible.
That's a very practical advice, and just elaborate a little bit on that before we finish with you, Paul. If you were to say, what are the most prominent lifestyle risk factors that you'd be saying? I mean, obviously you've mentioned weight. What other ones would you be encouraging? Yes, because some people have mentioned alcohol here in the questions. Is alcohol a contributory factor?
Yeah, so with alcohol now, so for some people, alcohol can be a trigger, but certainly they sort of say to limit your alcohol intake, and to, sort of less is more in the setting of atrial fibrillation. Good blood pressure control and good diabetes control.
Okay, very good. That's very good advice. And Eileen, as somebody who has this lived experience, and also on the other end, you're in your day job, so to speak, working with people who are challenged by the trauma of, well, in this case, the trauma of a diagnosis or the anxiety of it. Any take-home messages from tonight's discussion?
I think everything that was said there, in the sense of, doing things in moderation, exercise, diet, all of that. But you also need to take the fear out of living, because, if you are doing everything really by the book and taking your medication and all of that, but if you're constantly kind of are very anxious and worried and in fear of, your life, my message, I suppose, would be is, if you've had a diagnosis, you're in the system now, you know about it, empower yourself a little bit more, find out as much as you can. You can make changes in your life. You can do the things you were doing, but maybe do them differently and in a different manner. And I suppose, just being able to take the fear out of it a little bit, try to live, because you've been given a second chance to live if you've been, if you're at least if you're being diagnosed and you're on your way. So taking a little bit more care, I think, of ourselves, and trying to lose some of the fear, because that can be just as dangerous as you know, anything else to us.
Yeah, well, no, it is great to end on a positive note, and sort of focusing on the positives that I've just heard here. Professor Lyne has pretty much said, look, there are many treatment options, so it might take a bit of time to get it right, but there are options. And as you rightly point out, Eileen, knowing you have atrial fibrillation is a big plus, because we don't know you have it, and it doesn't have symptoms, then it can be very serious. So you got to take the positive of that, and as you rightly say, then learn to manage it. It's like living perhaps with other chronic conditions, and use techniques that you know, anything, I guess, from mindfulness and yoga and relaxation and so forth. These are all part of the coping process. Fantastic. Really, I genuinely didn't feel the time passing, and I hope those listening have found it equally the case, and that they've got some useful snippets of information and advice from this session. Before we wrap up, for all of you that are still with us, and there's quite a few, which is great to see, there will be a post-event survey. So you'll receive this by email, and we'd really ask you to complete that and return it to us, because that survey basically helps inform us around how we're doing in these type of sessions and what types of sessions we should move to and so forth. Secondly, can I again thank our sponsors? If I omitted to thank them at the start, my apologies. An event like this, obviously, we greatly appreciate the support of Johnson & Johnson in this instance. And I would draw your attention to a very informative website that they have recently launched, getsmartaboutafib.ie, and there's loads of information there. So check that out when you get a chance, getsmartaboutafib.ie. And if I could then, because reference was made of this earlier, remind you of the Croí HeartLink West service. This is a free nurse-led helpline, and this is available Monday to Friday, and you can call our helpline, which is an 091 number, 544 310, or email healthteam@croí.ie. And this is really here to provide support, signposting, help you in any way we can. It's a nurse-led multidisciplinary team responding to those calls. And as an offshoot of that, there are then opportunities to get perhaps one-to-one conversations. Now, currently this is done virtually, or in fact, group sessions. So what we call the HeartLink West virtual chats. And this is an opportunity to have face-to-face Q&A session with our health team, and they cover all sorts of health-related topics, from atrial fibrillation, blood pressure, diet, exercise, and much, much more. And they take place virtually via Zoom every Thursday morning at 11 a.m. A different topic is covered every week. Next week's chat is Exercise is a Powerful Medicine, and that's going to be delivered by our exercise specialist, Caroline Costello. So again, if you want more information about that number, about that session, 091 544 310. And don't be afraid, if you haven't used Zoom or any of these modern technologies, we have somebody who will help you and guide you through that process. And again, any queries, email healthteam, all one word, @croí.ie. I'd also ask you to put a date in your diary, and that is August 26th. And that's the next session that we'll be having available to the public. It's part of our Croí Mice Launcher program. This is an initiative that Croí has launched over the last year, generously supported by the Sláinte Care program. And the session will be on living well with cardiovascular disease, the emotional recovery, some of the stuff that Eileen would have touched on this evening. So that's Thursday, the 26th. It's free, and you register now at www.croí.ie/webinar. And the program will be up there with speakers in the coming days. Before I close, I really want to thank my own colleagues, the backroom team, who are literally run off their feet, so to speak, in answering the many queries and questions that have been coming in all evening. And again, to say to you, obviously we just couldn't answer every question, but we will endeavor to get back to those who have posed questions, or point them or signpost them to where they can get the answers to the queries they had. Thank you again to our supporters, Johnson & Johnson, but most importantly, can I thank you, Professor Lyne, you, Paul, and you, Eileen, for a very informative conversation this evening, and really appreciate you giving your time. And I think at that, we will sign out and say goodbye to all of those who are still with us on the line. And I hope that you at home have got some benefit from this session this evening. So we'll just say good night and thank you very much.
Yes.
Thank you.